I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm Dr. Jordan Robertson, and I am your host. Before we get going today, I actually have some cool news to share with you. The podcast and myself as a clinician have both been nominated for awards. We have been nominated, I say me and the podcast. So I have been nominated for these awards by my colleagues, which is open to public voting from October 3rd to October 9th, 2020. If you've listened along to the podcast, if you've benefited from any of the information that we put out on social media, through the podcast, through the blog, or if you've worked with me one-on-one as a patient, I would be eternally grateful for a click and vote for us to be recognized again by my peers. The link to the awards, which are called the Paragon Awards, is in the show notes. So hit pause, take a second, flip over to that website and give us a vote, both for Clinician of the Year as well as Podcast of the Year. Really is quite an honor to be recognized, but also it speaks volumes to the kind of impact that we're having at a more macro level with women and giving women the access and tools to help advocate for better healthcare for themselves, which is an awesome lead-in to the discussion that we're going to have today, which is around heavy menstrual bleeding. And I think that this is an important topic. I've lectured about this to my colleagues quite a bit. I think we underassess women when it comes to heavy menstrual bleeding. We also, as women, sort of normalize this idea and concept of period symptoms. And women often have made, sort of creative reasons for why, in their head, for why they may suffer with specific menstrual conditions. What we often will see is women say, well, my mother and my grandmother had terrible periods and therefore I have terrible periods. Or, they don't have a sister to compare against. And so instead of, discussing their complaints openly with their girlfriends and with their mother or with their doctor, they actually assume that their experience is normal. And I see this working with women with endometriosis, where their time to diagnosis absolutely is delayed on the end of the practitioner, right? On the day that they present. I don't know if we're assessing them thoroughly enough to find endometriosis, but also it's on the end of the woman where she delays getting treatment and delays getting assessed because she's normalized her pain experience. We see the same thing with heavy menstrual bleeding. And what I wanted to focus on today is looking at heavy menstrual bleeding kind of across the lifespan, because the causes for it are different depending on where women are at through their reproductive lifespan. And I want you to have some of these like token keywords and language to be able to describe to your practitioner what's going on so that you can get properly assessed. Because that's really what it comes down to with heavy menstrual bleeding, is that you need good assessment, because the treatment really needs to follow whatever the underlying cause is. There's not that many solutions that we can just give women that, would miraculously cure all causes of heavy menstrual bleeding. We literally need to know what's going on in order for us to apply, appropriate treatment. So heavy menstrual bleeding is defined. It's actually defined by a certain number of milliliters of blood that's lost I think in the medical literature, we've done women a bit of a disservice by saying that women typically don't know if they have heavy menstrual bleeding, or women say they have heavy menstrual bleeding when they don't fit the medical definition of heavy menstrual bleeding. And that, I mean, as a woman, I find that just downright annoying, right? Because to me, I feel like if you think your heavy menstrual bleeding is heavy, then we should probably just listen to that. I also want women to be quite mindful of change in flow, which when we've put sort of a, stop date or stop number on what we would consider to be heavy menstrual flow in the medical literature, saying like it must be above 80 milliliters of blood, then what we're doing there is that if a woman's normal menstrual losses are quite a bit less than that, and then they have a change, but it's not 80 milliliters of blood lost, they're not fitting the diagnostic criteria for heavy menstrual bleeding, but yet we should probably just listen to that. So the literature does say that many women don't have a good assessment. This is also predates a lot of the menstrual cup use, I will say. So there are pictorial assessments where we get women to actually point to pictures of pads, cartoon pads, to say how much blood they're losing over a period of time. That can be quite helpful. But I do find now with the transition of more women using a menstrual cup that women actually maybe have a better idea of how much blood loss they are having. Because there's a graded, measurement on the side of their menstrual cup. So I think the research on whether or not women know enough about their menstrual period to be able to accurately tell their doctor is probably outdated. And yet this is a real driving force in how we treat women medically when it comes to their period. So they land on their doctor's doorstep and say they have a heavy period, but the doctor has read years of literature that opens with women have no idea how much they're bleeding. And so automatically that means we're kind of discrediting what she says, even though I think today's modern woman has a much better idea of how much blood loss she has versus the women that are in the last decade of studies when we've really started to pay attention to it. So there is sort of a actual definition of heavy menstrual bleeding. And there is, like I said, there is this little pictorial chart that you can look at. And if your doctor is not sure, if they are not totally believing your story, you should be able to point to a pictorial chart and show what your blood loss looks like. We typically will also ask questions like, well, how often are you having to change a pad, and how quickly do you bleed through a tampon, and are you experiencing leaking even though you're using protection? These are great questions to for practitioners to ask their patients, but also for women to be able to communicate to their doctor so that she gets the appropriate kind of care. So the actual act of menstruation is built over 28 days, or whatever your equivalent normal cycle is, which there is some degree of variance there, right? We may still call a 26-day cycle normal. We may still call a 32-day cycle normal. So there is this month-long, we'll call it, process that builds and grows endometrial lining, that matures that uterine lining, and then sheds that uterine lining. And it is a stepwise situation that happens that's triggered by healthy hormone release. So as we start to look at the causes of heavy menstrual bleeding, some causes are just downright structural, where women may have things like fibroids, they may have adenomyosis, they may have had other growths, right? Which it's for some women, and we'll talk about when this becomes important through the lifespan. They may have had other growths like polyps, and they may have growths that are actually more sinister, like malignant growths. So there may just be a downright structural issue that's coming up that's causing heavy menstrual bleeding, or it may be non-structural. And again, we'll talk about when these things become appropriate, but a non-structural cause would be things like a hormone imbalance. It would mean like maybe certain conditions would cause heavy menstrual bleeding. Certainly there are some medications like blood thinners that will cause heavy menstrual bleeding. Even if women have an inherited coagulation issue like a platelet disorder, they may have heavy menstrual bleeding. And so there's structural and non-structural causes. And even in those non-structural causes, when we say hormonal, there are many hormone dysfunctions that will cause heavy menstrual bleeding. So you can see why the assessment piece is so important, that even just having a woman describe what she's going through, we very, very rarely could tell just by looking at her what the issue was, right? We need to apply some kind of assessment for us to figure that out. And that's why I want to go through this with you, because I think it gives you some of the sort of thoughts and language on how you can approach this conversation with your doctor. And if you're a practitioner that's listening, this is a good refresher that we need to be really thorough when we're working through our causes of heavy menstrual bleeding. I commonly work with adolescents who have heavy menstrual bleeding in their first 3, 4, 5 years of having their period. This topic is like near and dear to my heart for lots of reasons. This is a primary reason why women quit sport. So young female athletes who struggle with heavy menstrual periods often leave their sport before their male counterpart, right? So if we think about teens transitioning out of competitive sport for various reasons, for young women, having menstrual fears around heavy bleeding is often one of the leading causes that young women will leave sport. The other reason that this is such a passion topic for me is that it's actually their sport and their nutrition that are often sort of fuel to the fire as far as their menstrual concerns. And so what I would love is for these young female athletes to have the kind of healthcare support that actually lets them be fueled well enough to compete in their sport, but also to not suffer from menstrual irregularities. So when women are young, as they start to go through menarche, that first menstrual cycle, their brain to ovary axis, right? So it's called the HPO axis. So the hypothalamus, pituitary, ovary. These are 3 major hormone producing sites. Hypothalamus and pituitary being in our brain, and then ovarian hormone production. There is a whole sequence of events that needs to happen between those 3 sites in order for us to have a regular menstrual cycle. And really, when you finally understand how the menstrual cycle works, it's quite a miracle that all of these steps happen in this like sequential order. And you can see why it's so easy for women to have menstrual irregularity, actually. So the most common cause of heavy menstrual bleeding in young women, so in adolescence, is a disruption of this axis where it's immature, it maybe hasn't quite fully developed. This axis in young women is particularly sensitive to their nutrition and to the number of calories that they eat or their exercise. So you can see, like in this sensitive age where many women struggle with their nutrition, many women struggle with or are verging on, disordered eating. Many women are in competitive sports but don't have the nutrition, right? They compete like an Olympian, but eat like the average Jane. These axes are very susceptible to the teen's lifestyle, as well as they're just straight up immature. So for some women, it takes them a few years for them to reach sort of slightly better menstrual maturity where they will ovulate on a regular basis. So the reason that they get these heavy periods is because of, instead of having this sequential 4-week situation where every week is growing and maturing uterine lining in a staged approach, they get haphazard hormone production. And so they may grow endometrial lining, they may not mature endometrial lining. They may grow endometrial lining and then produce no progesterone because they don't ovulate. And without parts of that sequence, the endometrial lining that then does get shed when they do, if they do, right? So lots of young women in this time will also skip periods occasionally. So when they do bleed, it is a much heavier experience because that uterine lining has missed some of the cues of what to do. And so instead of having this 4-week growth, maturation, sort of thinning process, and then a nice regular menstrual cycle, they get these anovulatory cycles or these cycles where they don't ovulate, and that causes heavy menstrual bleeding. So that is something that's important to look at. The other one is that polycystic ovarian syndrome in young women, which this is commonly when we start to recognize in these young women that they have menstrual irregularities. Some of it might be due to, like I just said, this immature HPO access, but some of it might be due to polycystic ovarian syndrome, which is the most common hormone imbalance in young women that also causes anovulatory cycles. And so although some women may go months without a period, which certainly should also be investigated, some of these young women with PCOS have very significant and heavy menstrual bleeding as a consequence of them not having that regular hormone production. So very important to have that looked into. There are some simple blood tests that can be done to help understand if young women are ovulating, but those are kind of the most common causes, is actually hormonal in young women. Certainly in young women who have really heavy periods that we can't figure out why they're happening hormonally, probably should be screened for a coagulation disorder. That's like up there actually as one of the more common causes of heavy menstrual bleeding in young women because they don't have the structural changes yet, right? So a lot of these structural changes that cause heavy menstrual bleeding are something that we see show up much later in a woman's life. So young women, we're typically looking at anovulatory cycles or irregular hormone production causing irregular growth of the uterine lining, causing heavy menstrual bleeding. Now, as we transition to talking about sort of all women moving through adolescence, there are some non-gynecological concerns for us to be looking at as far as causes for heavy menstrual bleeding. So that whole process of shedding the uterine lining does require coagulation, meaning clotting. And there are some underlying health conditions that are quite common in women that will interfere with your body's ability to clot effectively, which will cause heavy menstrual bleeding. The two sort of more common ones that I will see in clinical practice is iron deficiency and thyroid disease. So iron deficiency and hypothyroidism, both in different ways, interfere with coagulation, meaning that it's slower for your body to clot. And when those uterine arteries or uterine tissue starts to be released, it requires clotting in order to stop. And so both of these conditions actually will increase that clotting time, meaning that there's greater blood lost. So, iron deficiency is incredibly common. It's like endemic in women globally, not just in North America, and definitely should be screened in women who present with heavy menstrual bleeding. It's funny because we think of, if I say to women that I'm working with, oh, you have heavy menstrual bleeding, we need to test your iron. Their thought process is, well, for sure, because I'm losing so much blood every month. But my reasoning for doing it absolutely includes that, but does, it's part of that assessment process to figure out the cause of heavy menstrual bleeding. And it could be from low iron, even though this becomes a bit of a vicious cycle, because the more that they lose, then obviously the lower that their iron is. And so we definitely want to screen for that. And both hyper and hypothyroidism influence menstrual bleeding and menstrual clotting in different ways. It's kind of beyond the scope of us having a conversation about it today. Maybe we'll save that for another day. But they really should be screened, especially in women who present with other symptoms like fatigue, who sort of fit that picture of maybe subclinical hypothyroidism. We do want to screen TSH to make sure, like that's your thyroid stimulating hormone, to make sure that both that and iron are sort of in good standing, to make sure that that's not the cause. And actually many papers that have discussed the most common causes of heavy menstrual bleeding in adolescents still list thyroid disease and, interfering with clotting, which includes iron deficiency as, things that we need to consider. The list for adolescents gets quite small after that, things that will cause menstrual bleeding like an ectopic pregnancy or some sexually transmitted infections will also cause uterine bleeding. So certainly like the frequency of those things is very low. But if you're listening and you're thinking about, a young teenage daughter or a young woman that's in your life, or maybe perhaps it's even yourself, You certainly, again, want this heavy menstrual bleeding to be checked out because even though it is a small percentage, there are some more sinister causes of heavy menstrual bleeding beyond the couple sort of heavy hitters that I just talked about. So as women transition through their reproductive years, the causes of their heavy menstrual bleeding certainly can still include thyroid disease and low iron, because they're definitely prominent in that age group. But interestingly, as women get older, the likelihood of having structural causes goes up. So our need for a uterine ultrasound as a part of your diagnostic process definitely goes up. I'm not saying don't do it for adolescents, but they're less likely to have a fibroid or to have a growth in their uterus as being the cause. Whereas I do find for women in that perimenopausal, those perimenopausal years, like I'd say anywhere over 38, I think the more I learn, the more I back up the date that I'm willing to consider women being perimenopausal. I used to say 45 and up, and then I always say 42 and up, and then 40, and now I just lump myself into that age group at 38. As women are really over sort of 35, 38, getting close to 40, they start to have hormonal changes and structural changes that may influence the heaviness of their menstrual bleeding. So those structural changes are important to have assessed. And the reason being for that is that depending on your age, really, your treatment may need to change. So for women who have really significant fibroid growth in their late 30s, we really need to have a frank conversation about what we're willing the next 12 years to look like until they reach the natural age of menopause, or whether or not they deserve to have more aggressive and more permanent solutions such as surgery. So if you are in your late 30s and you've started to experience changes to your menstrual bleeding, an ultrasound, it needs to be done. It really needs to help us get this baseline to understand if there is structural reason. Because like I said, we can throw treatment at you all we want. Often women who have heavy and irregular periods after 35 get offered either the birth control pill or an IUD. And I'm not saying that either of those two treatment options are wrong, but they're using a hormonal solution to treat a structural problem. And I just want women to know the reason why they have heavy menstrual bleeding, even if the treatment doesn't change. But sometimes when we're going to apply the same treatment either way, we don't always follow through with really accurate assessment, right? Because it's almost, not justified to do all these tests if the answer is an IUD. I would sort of beg to differ because I think women, deserve to know what the cause of their symptoms are, but it also would maybe help better inform us for how we should treat this woman as she does approach the natural age of menopause. Women who have fibroids are often told that they can't use hormone replacement therapy, which isn't completely true. And so I want women to have a really good lead time from the time they're diagnosed until the time we transition through menopause so that we can have these conversations about what our goals are around their treatment. So both fibroids, adenomyosis, they cause a thickening of the uterine wall, which obviously increases bleeding, partly just from increasing square footage, but they also cause a lot of inflammation. And as women get older, there are more sort of inflammatory, I'm saying that in air quotes, inflammatory reasons why menstrual bleeding changes. So interestingly, women in perimenopause and maybe closer to 50 and maybe not my 38-year-old peers, we actually also don't ovulate every month. So similar to our adolescent women who have these changes to they basically don't have regular ovulation because their menstrual cycle is not mature. As women sort of approach perimenopause, their menstrual cycles also are not as regular. And progesterone really is a very important hormone for supporting endometrial lining. It actually is anti-inflammatory. It regulates inflammation in the uterine lining and helps decrease the amount of bleeding that happens in every cycle. So in these non-ovulatory cycles, so basically, and just to back up, when we ovulate, that's what makes progesterone. So that entire hormone's production hinges on you ovulating. So when you don't ovulate, you don't make progesterone. Progesterone's natural role in the uterus is to, and you always use the word mature the uterine lining, and I will say medically, that maybe is not completely accurate, but it gives a nice visual on what happens. Progesterone matures the uterine lining before or preparing for pregnancy, but it also does it to prepare for each bleeding episode or each menstrual cycle. When progesterone is withdrawn at the end of the month, right? So meaning if you don't get pregnant, after 2 weeks, your progesterone production declines and we start another cycle. As progesterone declines, then we actually have an increase in bleeding, and that's what's supposed to happen, an increase in bleeding. So when progesterone is not there at all, right, then we don't get this like inhibitory effect that it has in the uterus. So I'm going to say it in a different way, just because I think I'm talking myself in circles. Basically, progesterone stops bleeding, right? So in those second 2 weeks of your menstrual cycle, you ovulate, you make a lot of progesterone. In those second 2 weeks of your menstrual cycle, you don't bleed, or you shouldn't, right? And again, this brings up this whole idea is if you're spotting in those 2 weeks, we want to check your progesterone levels. But in those 2 weeks, you make progesterone, you don't bleed. And then as progesterone levels fall, naturally at the end of those 2 weeks, that triggers bleeding. So now you can see what happens if you don't ovulate, if you don't make progesterone, or if you make very little progesterone with a kind of poor ovulation, is that we have more bleeding. So as women transition towards perimenopause, sometimes their menstrual cycles get very heavy because they're missing part of those hormonal triggers that are supposed to happen every week of the menstrual cycle. So women who have heavy menstrual bleeding, their uterine lining actually just is straight up more inflamed than women who don't. So if we sample their uterine lining, they have more enzymes and more inflammatory markers in their uterine lining than women who have regular menstrual cycles. And that loss of progesterone actually really just amplifies this whole situation. And it triggers the blood vessels being open, it triggers or prevents clotting, and way more blood is lost as a result of not having that good hormone production. So the other reason that I like to have this discussion with women who are perimenopausal is, again, to not normalize this experience of heavy menstrual bleeding. And it's common. And if you talk to your girlfriends or colleagues or sisters about the changes to their cycle as they age, they talk about it as if it's almost, I don't want to say rite of passage. That's not the right word, because rite of passage makes it sound like we were excited about it. But it sounds like it's something that we're destined to experience, right? Oh yeah, my cycles got a whole lot heavier when I got older, right? Or welcome to your 40s. This is where you lose all your blood. Like, I don't know where these phrases come from, but they're common, right? This kind of concept that women can expect changes to their cycle as they age are common. And absolutely, you can expect to have changes to your cycle, but that doesn't mean that they should be unaddressed. Because even if we think back to earlier in the conversation, many of those causes that I was discussing, right, whether we're talking about, clotting issues or iron deficiency or thyroid disease or polycystic ovarian syndrome or other anovulation causes, especially in young women, caused by either disordered eating or underfueling. In older women or in women who are in their 30s who notice remarkable changes to their menstrual cycle, it could be caused from early ovarian failure and ovarian decline. Heavy menstrual bleeding is like the tip of the iceberg for all of these conditions, right? It is like the most outward experience of those conditions, perhaps. But the inward things that are being caused by those conditions, or the under the surface downstream negative effects, are really significant. So having women walk around with undiagnosed hypothyroidism or undiagnosed iron deficiency, or a teen who has an unassessed eating disorder or who is underfueling for their competitive exercise, or a woman who's in her 30s that is having premature ovarian failure, which is why she's not ovulating, but because she's still menstruating, we're kind of ignoring it. All of these reasons are significant and cause much greater long-term health risk in women than their sort of simple, heavy menstrual bleeding. And that's what drives them into the doctor's office. Why they go to the doctor is because they have these horrific periods. And they leave with a solution perhaps, that doesn't actually dig deep into the reason for why they're having it. Or we normalize the reason why she's having it without having a much wider discussion around how that is going to influence her future health. So this is why this topic is so important to me. Because again, when we talk about like women's health advocacy, we're doing nobody any favors if A, we don't believe women when they walk in the office. Remember, like back at the very beginning of this episode, I said, you know what? The research actually says don't listen to the women, right? Like the research literally says women have no idea whether or not they have a heavy period or not. I think that that's not true, or I like to think that that's changing. I think with better menstrual cycle awareness, that perhaps we can take away some of the subjectivity around heavy menstrual bleeding. But, women tend to even not be heard that well when they discuss this, or we normalize the experience, welcome to postpartum, your body's changed and things will never be the same. And here you go, here's heavy periods. And or the solutions that we offer are not, looking at that deep root cause, which means that part may be left unassessed. And I will say like that uterine ultrasound needs to be really high up on the priority list as far as assessment, especially for my older women who very likely have some kind of structural cause of their heavy bleeding, so that we can have a good conversation about what a longer term solution looks like, especially if your goals are to avoid some kind of hormonal contraceptive. Generally, the evidence is the best for the IUD. The IUD works very well to deal with heavy menstrual bleeding, and I'm certainly not against that option. I think for many women, this is the quality of life improvement that she can have with an IUD is beautiful. There are other treatment solutions, and some of them even address the inflammatory component of heavy menstrual bleeding. And there are hormonal solutions as well, right? When we're looking at and natural, I shouldn't say hormonal. I mean like micronized progesterone or natural progesterone can also be used as a treatment. So again, it depends on what those causes are. And really talking about treatment is something that should be done with your practitioner. But what I want you to go into that conversation with is the ammo on how do I get properly assessed here? How do we actually explore this? How do we get curious about what's happening? Because it's not happening by accident. And I want you to know that sort of deep inside so that you can advocate for a good healthcare experience when you approach your doctor. I'm sure that none of you are as passionate about heavy menstrual bleeding as I am. Although maybe after listening to this, you can see why it's such a feminist issue for me to help women get better assessed. And I hope you enjoyed that episode. I'm gonna suggest two things to you. One, I would love if you'd take a second to give me a vote for the podcast of the year. I am so grateful for the opportunity to have this platform to share information like this with all of you. I would also welcome you to join our Facebook community, also called Women's Health Unplugged with Dr. Jordan Robertson. This is a place where you can ask questions, where we can connect. We do share videos and short little snippets about each of the topics that we talk about in the podcast there, do live videos, blog posts, etc. And so if you haven't reached out and joined our community there, I would absolutely love to see you there. We're working on a couple of Ask Me Anything style podcasts, and that would be a great space for you to connect with me about some of the burning women's health topics that you want us to cover over the next coming months. I hope you enjoyed that episode of Women's Health Unplugged. It's my absolute passion to bring women quality and science-informed information about their health so that they can make empowered, good decisions about their health care. I'd like to invite you to join me in my Facebook community, Women's Health Unplugged. There we share live videos, blog posts, and behind-the-scenes information about the podcast, where you can connect with me and other women who are interested in their health care. You can find us at facebook.com/groups/WH Unplugged. We'll see you there.